Right, welcome everyone to today's meeting of the Health and Wellbeing Overview and Scrutiny Committee at the Council Chamber here on Tuesday the 1st of April, 1 p.m. It's past 12 o'clock, so you can't do any of that silly business. Number one is apologies for absence. Do we have any apologies for absence?
Chair, I've got apologies from Councillor Chicken.
Thank you. Item 2, disclosure of members' interest. Does anyone have an interest to declare? No, thank you. Then it's item 3, which is Northumbria Healthcare NHS Foundation Trust, NUTH, quality accounts. The annual report on the quality of service. The committee is requested to receive and comment on the presentation from each trust and to agree to submit a formal response. So I'll pass over to yourselves.
Thank you, and thank you for inviting us today. My name is Chris Jenkins. I'm Director of Performance and Governance at Northumbria Healthcare. I'm joined by my colleague Paula Chandran, who's Head of Patient Safety and Governance. So if I could just start off by just quickly describing how we do our annual plan and kind of how we've built it up. So we're in year 3 of our 5-year plan, and we build up the delivery of what we want to achieve in any particular year through our big signals, which you can see on the screen there. And all our work hangs from one of these 8 big signals, and the work drives up through these in order to kind of make sure we're hitting all the areas that we need to achieve. So that's the kind of the internal bit. This year, the kind of the external context, the national context, is around and a lot of our planning is built around what's been termed as the three shifts. So that's around shifting from treatment to prevention, shifting from digital to analogue, and shifting from hospital to community. So a lot of our planning and our plans for next year are built around those 3 big shifts, linking back into our big signals that we've had for a couple of years now. And our business units, which are our way we do business within the trust, are all aligned to these principles. So in terms of kind of a quick review of this year, I don't think anybody who reads the press or maybe accesses ours or others provided services will come as a massive shock in terms of the continuing demand for non-elective, sort of urgent and emergency care, and we can see that through the numbers attending our various sites across the county. We've had a number of mitigating actions in place to try and improve our performance, improve our access to services for our patients. And we have had some success or some good success in many areas. One of those areas around cancer and reducing the number of cancer backlog patients and also that access again to cancer treatment. We've had, can see good progress in that area. Similarly, elective, so that's anything you get referred through from your GP into secondary, into hospital services. Again, the demand is high in those areas, and we're really focusing on particular pathways where we know we have improvements to make in terms of that access to those services. So I guess to sort of summarise in terms of the service pressures and how we're doing in the last year, we're doing well. We're doing well relative to others in the region, others nationally, but we know we're not where we need to be or indeed want to be. And the other external context that we'll have in the coming year is this kind of refocus on what we term as the constitutional standards. So things like how long you wait for that referral from your GP into hospital services, how long you wait if you turn up at A&E, how long you wait if you have a cancer referral. So we're really keen to get back that focus and get back to where we need to be on those areas. So in terms of the quality count, we're again following the same process we do every year. So this is that review, that look back about safety and quality and improvement priorities for last year, and also that look forward into next year. So it's a requirement for all foundation trusts to do this, and we'll follow the same process and timelines as usual. So we're working on the draft account in a minute. We'll have that ready by the end of April, and we would invite formal opinion back from yourselves and other stakeholders in May, with looking to get that submitted to NHS England for the end of June, and I think it has to be laid before Parliament, I think sometime in July. So I say we will get back to you with that draft in the usual timescales by the end of April for that comment into May. So if I could just hand you on to Paula now, just to go through our safety quality improvement priorities for last year, and more importantly, I think, for next year as well.
Thank you. So there will be some that will continue into the next year, because it's usually a 2-year cycle that's identified. Unless there's significant development and progress, then they'll they will go off and they'll progress into core areas of business for the trust. So the ones where there's been really good improvements across the last 2 years have been the medication delays in patients with Parkinson's disease. There's still some improvement work within the emergency department around that, but the wards, there was some focus wards particularly piloted over the last 2 years, and there's been significant improvements. Training and development for our staff will continue in this area, and there's World Parkinson's Disease coming up in April, so there will be a focus around this during that time as well. There will be a cancer priority going into next year, and the urology pathway is being looked at across and in terms of Newcastle as well, in terms of the collaboration. So although it won't be a specific priority for the SQ&I priorities, it will still be a trust priority as part of the urology pathways, because we know that that's an identified area that needs to be looked at across the trust. And I'll, when I go on to the next slides, you'll see the cancer one that's been identified for the next 2 years. And the other one is the urinary tract infections. There's been some progress around that. So you'll see in the slide pack that actually the improvements haven't been as where we want it to be, but actually from the Q4 data, which isn't in the pack because that was at the time it was done in terms of Q3, there's been progress in that area that has been met. And that will continue as a priority for the trust, but not as a specific safety and quality priority. Bed rail and bed height risk assessments, brilliant development in relation to that, and the compliance is over 90%, and that has been over the last 2 months. So what will happen with that is it'll go into what's called our ward assurance framework. So it's a monthly audit across the wards to ensure that the bed rail and bed height risk assessments are looked at, but that it's embedded as well in terms of the compliance around that. So that will come off, but it will continue in terms of the trust oversight. And I'll go on to 25, 26 now. So we have identified this year's priorities, and that's been with a number of events and stakeholder meetings in the trust to identify these. So they have had sign-off, and they'll be going to governors in April to get the final sign-off. Some of them have also been identified through our patient safety incident response framework, which in the trust has been embedded now for a year, came into place in 22 for NHS England. And some of the learning that we've seen coming from the patient safety investigations has now helped us identify the priorities for the next year. So there are 8 for next year, and some are building on improvement work that we've already done. So the pressure damage, that will continue into this year, into a second year cycle. In terms of improvement, we haven't seen where we want to be with that yet, because our DATEX reporting system slightly changed, and what we did with that is we now capture ungradable and deep tissue damage, which we hadn't done previously through our DATEX system. So that's really good progress that we're able to do that. But also in terms of our ward staff, they validate the pressure damage now within the ward areas, which means we're getting accuracy around that. So we'll start to see improvements around that, hopefully in the next 2 quarters. So in terms of the measurement of this, we'll be doing it, a focused piece of work around this, and we've done some after action reviews looking at themes that have come out of the work that's been done, and then identifying the learning for the next year in relation to that. Postpartum hemorrhage within maternity, that will remain as a priority going forward. A contributory factor to that is over 40% of our births in our trust are caesarean births, and the blood loss with caesareans is approximately 1 litre. So 0.5 over that is, as you can imagine, when you see the caesarean scope, we're naturally going to see an increase in the PPH around this as well. But that will remain as a focus project for this year. Deteriorating patient, that will continue into its second year with a new recognised measurement around high lactate for patients, and that's making sure patients are seen at the very earliest opportunity by our critical outreach team when they present into the emergency department. Staff and patient experience, we always have that as a continual priority, and this year we're actually working across the collaboration with Gateshead and Newcastle as well, looking at the ED emergency department patient experience data and triangulating that across the region to see what we're each identifying, to look at learning across the patch with that. We're also looking at the accessible information standard, and we've recently brought in a trust patient charter around expectations and behaviours around our patients and engagement around that. So we'll be looking at that this year. Cancer faster diagnosis standard, and that's looking at cancer being informed by day 28, whether diagnosed or not diagnosed, to look at the tracking across that and just to make sure that the patient experience is better around that, but making sure people are informed much earlier on if they've got cancer or not. Complaints process, we're looking at the NHS complaint standards has recently come in, so we've already got an embedded complaints process, but what we'll be doing is we'll be looking at the standards and benchmarking that with our current complaints process, and that's to make sure we have early resolutions for our complainants, that they're not having to wait longer than necessary, and also if looking at the duty of candour in terms of our incident reporting as well, and making sure where there's an apology needed that we follow this up verbally and in written when there's an incident. But also looking at training and education for our investigating officers and reducing the length of time of extensions of complaints as well. Health inequalities around endoscopy, and that's really looking, and that's in conjunction with our public health colleagues and surgery colleagues, and that's to look at our high deprivation populations and to reduce the do not attend rate with that, because we know it's higher around our deprived populations, and we're really trying to drive improvements in that area. We've already seen there's been a focused piece of work over the last 2 months, and we've already seen the non-attendance rate, a great reduction in that, so we know it does work when there's some focus work put in place around that. So that will continue. It's a new one in the next focus this year, possibly into the second year as well. And the last one is around the medicines discharge process. And this was identified through our patient safety incident reporting plan, which there were 2 themes from that. And that was around transfer of care and medication incidents. So we'll be looking at one area around the discharge process. Appreciate we've got to look at other pathways around that, but the first area that we'll look at is the medicines discharge. So we've now got a pharmacy lead within the patient safety team, and she's really going to help us drive this forward. And we have 2 trial wards, Ward 6 and cardiology ward within Wansbeck, and we're also going to look at the discharge lounge as well within the emergency department. And really look at the discharge checklist, but also the process for when people go home, that they've got the right medications and that it's timely and it doesn't prevent them being discharged as well, and staying in hospital longer than they need to. So as I've already said, next steps are that these will be signed off with the governors hopefully in April. They've already had internal trust sign off. And we'll be working across our colleagues as well in community to embed these, but also each of the priorities we have to link technology into them because it's so integral to all of this, so we'll make sure that's done as well with our IT systems and colleagues in the trust. Thank you, and happy to take any questions.
Councillor Hill.
Thank you, Chair. And before I say anything, I just want to say that if I sound angry and frustrated, it's not directed at you individually, and it's not. There are hard-pressed NHS staff, and it's not directed at them as well. But frankly, this is embarrassing. We've had this just presented now, and it does just seem like, and it's much more important than my historic work appraisals at school and so on, where you're just like, oh my God, I haven't hit my targets, haven't done what I've said I was going to do. Assurances you've given this to committee, and I'll just see if I can fudge my way through this meeting, which I can tell by your body language you're feeling uncomfortable, and I re-emphasise it's not your fault as individuals. But I mean, it just sounds like, even sort of reading this, it just sounds a fudge, and cancer targets are clearly being missed again. And, you know, I'm just trying to make my way. It's difficult to ask precise questions when it does seem quite a lot of waffle. And the excuse, you know, the target is to continue to try to meet national cancer standard targets, which isn't happening clearly. And the excuse is trying to recruit somebody to ensure patients were tracked effectively, and the excuse is that this person hasn't been recruited for. But let's get these sort of assurances that are going to happen next year that this person's now in place. I mean, really, is cancer waiting times and treatment reliant on one person? Nothing in this, I'm afraid, gives... We've had this every year. We get these reassurances and nothing gets better. And nothing about this fills me with any confidence at all, I'm afraid. You know, it's really disappointing.
Do you want to respond to that?
Yeah, no, yeah. I guess the proof's always in the pudding, isn't it? The proof's always like, if you say you're going to do something, have you done it? I think if we haven't done something, we just need to be honest and say we haven't done that. And I think that's what I think we've tried to do in here. You know, this is what we thought we could do, this is what we've tried to do, this is what we've aimed to do. If we haven't, this is where we haven't done it. So that's what we've done there. Are we happy with that? Well, absolutely not. No. Do we want to be better than that? Yeah, we do. And that's what we're aiming to do next year. We can only come back next year and say, have we done that? Yes or no. But our aim is to do that. Our ambition is to do that, and we're working extremely hard in order to do that. Is what we can, can say today. Can I give you absolute assurance and guarantee that we'll hit every target? In all honesty, I don't think I can give you that today. I don't think any trust in the country could give you that today. But we'll be having every effort and endeavour to do that, absolutely.
I mean, to be fair to you, I mean, it is a national problem, and the national targets are actually probably nowhere near good enough. They've been adapted to the fact that trusts across the country are missing these targets. And to be fair to you, when you talk about you can't talk about the wider NHS crisis. You can't talk about the fundamental change that needs to happen. So as I do emphasize, I'm not directing at you, and I know there's a bigger picture, but it really is pretty shocking what's happening in the NHS and these targets, which are, it's not in any sort of cliche or overdraft. This is missing these targets is costing lives and shortening lives. That is the reality.
So if I can just respond to that bit about the targets as well. So in the operational planning guidance that has come out from NHS England, they have, as you quite rightly said there, they have a level of target for cancer next year, for example. And then they have the constitutional standard. The constitutional standard is higher than that which NHS England want every trust in the country to achieve. So, and we are already achieving the level that's been set for this coming year. But as a trust and as a board, the board have said, well, actually, no, we keep the focus on the constitutional standard because that's where we need to be. And that's where we aspire to be, rather than saying, actually, there's a lower level of operational standard that's just coming for this year. So we still do have that focus on actually, this is where we were pre-COVID, and this is where we need to get back to.
Councillor Hunter.
Thank you, Chair. My question is on priority 7 on the endoscope, and you're saying that the more non-attendance is for the most deprived areas. I'm just wondering if it's where they're having to travel to, because it could be access to travel as well as the times of day. And I'm just wondering, are you actually following up as to why these people are not attending. It might not just be a choice, it might just be they can't get. And I think if we can deliver as much of this locally, you know, we're hoping for the new hospital we'll get that in Berwick, unless it's an emergency that they need. But I think it's trying to find out why, drilling down to why it is, and trying to deliver as much local to save carbon footprint.
Yeah, I can come in on that. So that's exactly what we need to look at, and that's exactly what was done with that population, because it was, you're absolutely right. It was the travel time, it was the cost as well, cost implications, it was the mode of transport, it was things in terms of dependency, in terms of, you know, they had dependent relatives to look after, which then they had also childcare arrangements. So it's looking at the local geography of it, and looking at, actually, is there somewhere else people can get their appointments? Does it have to be at one specific place? Can we look at the reduced transport of this? And so it is wider. So we have to absolutely work with our public health colleagues around this, and surgery as well. But that's exactly it. We can't improve it unless we look at the source of it. So yeah.
Councillor Ball.
Thanks, Chair. So first off, thank you for bringing the report. With regards to things like targets and things like that, I think we'd be asking more questions if you were hitting 100% on everything as well, saying, are these high enough? Are you actually really going for it here as well? So first off, thank you, and it's brutally honest. So my questions with regards to how you set the priorities and whether there's any impact on, so this year we're going to focus on 1 to 7. Last year's 1 to 7 are put to the wayside. Is there an impact on what was last year's priorities because we've picked up this year's? And just how do we maintain the good levels of improvement that you've seen from here to make sure that these new priorities are hit, but also they don't fall by the wayside? So just a little bit of how you set your priorities and what impact did it have moving priorities away from whatever happened last year's priorities? Thank you.
And again, you're right. Once the priority's closed, we absolutely need to make sure if it's been met, that it's sustainable, and that we look at it at 6 months' time, 12 months' time, to see where it is. And that's why what we do at the end of the year is, so for example, the falls that will and the bed rail assessments, they form now part of a monthly audit, and they're looked at through the monthly falls group. And if there's a concern, that will be looked at as core business. And if there's any quality improvement that needs to be driven from that piece of work, we'll look at it through a quality improvement project, because we need to still keep our eye on with those ones as well as the new ones. And then the new ones are identified. For example, there might be a patient safety incident investigation, and we see a common theme that comes out of those. And then that will help us look at, actually, this is a priority we need to look at next year. The patient and staff experience one we always keep as a core one. The cancer one we tend to keep as a core one. And then any new ones, it might be from a governor as well. So our governors are really important in identifying any new ones, or there might be a regional one as well. So actually regionally we're seeing something, a theme from an issue or a concern or a patient safety theme. And we'll look at it from that focus as well.
Can I just also to add that we don't necessarily, or we don't pick areas where we think actually we're going to absolutely sail this. It's going to be really easy and we'll get 100% in a year's time. As Paula said, it's about picking things where we know we have an issue, we know we want to make an improvement on. That might be hard within a year. Hence, I think it was 4 of them this year that have carried over, because we know we haven't made as much of a difference as we thought we could or need to in an area.
Sounds like you're ordering peanuts on the airline when you press that one. So can I ask, does any other member have any questions or points they'd like to raise before that? No, I'm not seeing anything. So with that, it says in here we've got to agree to submit a formal response. Is that correct? Is that just you making a note of this debate and these comments here, and that being submitted? And I'm sure we'll go from there. Yeah. Okay, great. Thank you. Okay, thank you so much for your presentation. Thank you. I'll go on to item 4 on the agenda, which is the report of the Cabinet Member for Tackling Inequalities, Moving in the Right Direction, Director of Public Health Annual Report 2024. Purpose of the report is to present the Independent Director of Public Health Annual Report for 2024. The report focuses on physical activity across Northumberland and highlights the way we can get more people active more often. And I think Jill Pryor is leading on this with the Cabinet Member.
Councillor Jones,
Yeah.
are you going to introduce?
Are you okay if I just say a few words? And it will be a few words. I'm not going to say very much because I'll let Jane take you properly through the report. It is the Director of Public Health's own annual report. It's not a council report. This year's is moving in the right direction. So it's an all you need to know about exercise, physical activity for adults, children, and what's available and what the barriers are. As always, the DPH report is interesting, full of information and enjoyable, and I think it's what I would call a really good read. So I hope you enjoy it. Jane, I'll hand over.
Thank you. Just very briefly from myself, this is, as you know, the independent report of myself, a topic of my choosing where I would like to shine a light of interest for the county. You'll recall last year when we focused on ageing well, this is a follow-on from ageing well because physical activity is both important for our physical and our mental well-being. It's always a team sport to produce a Director of Public Health report, so I'm delighted that we've got Jane Elliott with us today, who's going to lead us through the presentation. Jane's been a leading author for this, and I want to give a huge thanks and admiration for coordinating the team to get us to this point. It is a celebration of what is already happening in Northumberland and very much a call to action of what more we want to do. Physical activity is indeed free medicine, and the more we can do this, it will tackle inequalities and increase our life to years and not only years to life. So I'll hand over to Jane. Thank you.
Brilliant, thank you. So as mentioned, the presentation that I'm going to go through today is around the Director of Public Health Report for 2024. The topic for this year was around physical activity, and the title that we went with was Moving in the Right Direction, Increasing Physical Activity in Northumberland. So as mentioned, and as you may already know, every year we produce a Director of Public Health report looking at a certain public health issue or topic that would like to be highlighted. This report does play a really important role in informing local people about the health of their community, and also for providing information for commissioners and providers of services on certain health and wellbeing issues and priorities as well. So why did we feel that physical activity was an important area to highlight? Well, as mentioned, it's really important for individuals' health and wellbeing. So if we are physically active, we're more likely to have good cognitive and mental health. It can help individuals to achieve and maintain a healthy weight. It plays a role in preventing certain diseases, so things like cardiovascular disease or type 2 diabetes, and it can also play a role in things like strength and balance as well. What we also know is that we will see the biggest impacts when those individuals that are doing none or very little physical activity increase this up to around 60 minutes per week. Therefore, the report looked at supporting those individuals that were doing low levels to try and do a little bit more, as we know this is where we'll see the biggest health benefits and also public health outcomes. We also know if we have a county that is more active, this will hopefully help with our society and economy. So if individuals are more active, it can help to reduce pressure on our health and social care services. It can lead to things like increased levels of productivity at work, and it can lead to things like fewer occupational injuries as well. We also know if more people are using active travel, this can be good for our businesses and retail spend, as we know that people that are walking or cycling in local areas may use local shops or businesses, for example. We also know that being active can reduce the number of days lost through sickness absence, and it can also play a really important role in either managing or preventing long-term condition or conditions. So a little bit about physical activity levels in Northumberland. So we currently know that around 70% of adults are completing 150 minutes or 2.5 hours of physical activity a week, and this is similar to the England average. We therefore know that around a third of our adult population are not hitting the recommended guidelines for physical activity set out by the Chief Medical Officer, And of these 30%, around 20% are completing 30 minutes or less physical activity a week. In regard to our children and young people, around 50% are completing 60 minutes of physical activity a day, which is the recommended guidelines. And in regards to active travel, we have around 2% that cycle 3 or more times a week for travel, and around 10% that are walking 3 or more times a week. So our walking rates, they are significantly lower than the England and North East average, though we do acknowledge that due to the size and geography of Northumberland, it is often difficult for people to be walking 3 or more times a week for active travel. So the figures that I've just gone through, these have been quite consistent for around a decade now, which highlights some of the challenges that we do face in increasing physical activity levels across Northumberland. What we also know is that there will be certain groups within our communities that are less likely to be as active, and this is often connected with things like health inequalities. So we do know that we have lower levels of physical activity in our older age groups, women and young girls, some of our low income groups as well. We do know that certain ethnic minority groups are less likely to be active, people with a disability or disabilities, and people with a long-term condition or conditions as well. So linking into last year's DPH report, which was around ageing well, we know that being physically active as we get older is really important for health and well-being. It can help to increase years lived in good health. It can help us to keep independent for longer. It reduces our risk of things like falls, and it also plays an important role in our mental and social functioning as well. So as mentioned, there is some guidelines around how much physical activity we should be trying to complete. So for adults and older adults, that's 150 minutes or 2.5 hours of physical activity a week. And for our children and young people, it's 60 minutes per day. It's also recommended that we do some exercise that builds strength, and that's on at least 2 days a week. And really important is also reducing the amount of time that we are sat still or being inactive. As we know that independently, long periods of sitting still can be a risk factor for poor health outcomes. Within the report, we also talk about some of the barriers and enablers to being physically active, and we split these into 3 separate sections. So we talk about individual factors, social factors, and also our physical environment as well. And we know that a lot of these factors will interlink to all have an impact on how active somebody is. However, there is some factors that we know will impact on certain individuals and communities more often. So things like lack of money may have a bigger impact in some of our low socioeconomic groups, and things like poorer transport links may have a bigger impact in some of our rural areas as well. So as a team, it's important that we do think about some of these barriers and how we can support people to overcome these to be more physically active. But also, can we think about some of them enablers as well, and how we can strengthen these to support physical activity across the county. So moving in the right direction in regards to physical activity, it's also important we think about some of the opportunities that residents do have to be physically active. And in the report, we do talk about some of the work being done by Places Leisure. So Places Leisure have just completed the first year of their 10-year leisure contract, and they are taking forward a piece of work looking to work with communities within their local areas to provide opportunities, and this will hopefully make their service as accessible as possible. So moving away from that traditional leisure model where we would see all or the majority of the opportunities within the 4 walls of a leisure centre, and moving more towards working in communities, with communities, and also fitting the offer around the needs of them residents. We also talk in the report around an asset-based community development approach to physical activity, and we know that within Northumberland we have a number of key community assets that we can utilise to increase physical activity levels. So that includes things like local people with local knowledge and ideas, voluntary networks, the importance of public open spaces such as parks and recreational grounds, uses of our facilities, so things like leisure centres and religious and cultural venues, and also the importance of some of our local organisations such as charities and health services. The way that we design neighbourhoods is also really important in encouraging residents to be active. So if we have places that have local shops, have places to visit, have good outdoor spaces, then it's more likely that people are going to come out of their homes and move a little bit more. We also know if we have good walking and cycling routes, that will hopefully encourage people to be walking and cycling within their local areas more, rather than taking the car, for example. And we also know if we have good public transport links, this will hopefully encourage people to use public transport. And we know that on average, if people are using public transport, this can increase their physical activity levels by around 16 minutes. And that's by either walking to the bus stop or moving between different public transport links. So the way that we design our neighbourhoods is really important in supporting residents to be active. Within the report, we also talk about the importance of working together to increase physical activity. So whether that be within the public health team itself or across the council, or also working with our external partners as well. So we have started some work around increasing physical activity, around refreshing our physical activity strategy. And for this, we have done some sector-led improvement workshops. So these are 8 ISPA workshops, so ISPA standing for International Society for Physical Activity in Healthcare. And what these workshops do is they look at physical activity from a number of different angles. So looking at what's happening within our schools, within healthcare, our community-wide offer, and hopefully feedback from these will go into shaping our physical activity strategy going forward. We are also hoping this report will link into the work being done by our Healthy Weight Alliance. So the Healthy Weight Alliance does predominantly look at a healthy diet, but we are doing a lot of work around the built environment, which will also fit into physical activity. Also thinking about how we can link into some of our wider work as well, so work being done by the Institute for Health Equity and the 8 Marmot Principles, work within our county partnership, and also the Joint Health and Wellbeing Strategy as well. Within the report, we do have a number of recommendations that have come out of the report. So the first I've mentioned is the refresh of the Northumberland Physical Activity Strategy, and that's using feedback from them 8 ISPA workshops. We are also hoping to support the development of design codes in Northumberland, so that's around our neighbourhood design and also including our new county-wide housing strategy. We'll also continue to support development of good quality walking and cycling routes, and that includes some of our active corridors across Northumberland. We'll continue to support our new leisure and wellbeing contract, and particularly around reducing that inactivity gap and making our population more physically active. As mentioned, Places Leisure is also taking forward that active community offer, so supporting that to make sure the offer is inclusive. And also our last recommendation is around supporting communities to start new initiatives to being active. So that's linking into our work with Thriving Together and also our voluntary community and social enterprise sector. Thank you.
Okay, members, do you have any questions on that report at all? Comments? Councillor Ball.
Thank you. So this report, thank you so much for this. It's an absolute brilliant report. And really enjoyed reading it and all the different outcomes. And this is bang up my street. So I used to teach as part of the Age and Well programme. So I know the difference this makes, not just about the exercise, but that actual sense of community. The fact that if somebody in the second row isn't there that week, somebody else will check on to make sure everybody's okay. So that sense of well-being as a whole, not just the getting sweaty and everything else. It's that whole culture that comes with being out, being physically active and turning up week in, week out for your class, and that impact that it has. Stepping aside from the Age and Well stuff, I'm just wondering, in other parts of the country, we've seen the use of the childcare vouchers towards things like the physical activities, whether it be dance schools, karate and things like that, because sometimes that's where the child's interest lies. And I'm just wondering, I know there's a couple of barriers, is there any way that we can help to promote that as an option? Because I know some young people would love the opportunity, and due to some of that socio-economic stuff, they haven't got the opportunities, whether go to a dance school, go to a gymnastics club, go to boxing, but actually it might be able to tackle some of them economic barriers, but also get them more physically active and in something that long term, because we all know that them first years, it's almost what's your roadmap for the rest of your life, isn't it? So I just think if we could almost use something along that. But as I say, this is absolutely fantastic. And I just think when we look at some of the stuff around communities and how, whether it be we put some of the outdoor parks in and the walking and cycling stuff, I think some of the marketing around that at the moment, because within my ward, obviously there's this new active travel corridor, and I think a lot of people are just thinking that's just a cycle path, and when it is all done, it will make sense, but at the moment, it's just some of that marketing from our side of stuff of actually, it is a good thing for the communities to be able to link up, but absolutely brilliant report, brilliantly presented as well, and I can't wait to see some of them bigger impacts. But yeah, can we see the childcare vouchers used at all?
I think that's a really good point, well made, Caroline, and I completely agree. The social active component of physical activity is the game changer quite often, isn't it? Because it can take people out of isolation, and then almost the physical benefit is secondary in many ways. You raise a good point around the vouchers, and I want to take that away and have a look at that. Obviously, we do a huge amount with the holiday activity, with food funding that we get, got good relationships with Places Leisure and our trusted partners beyond the leisure contract to make sure young people are getting different opportunities just to spark that level of interest, and the work of the sports development team is linking in with a lot of grassroots clubs as well. So I think we've got a lot there and we can do more. So I take away that point, Caroline, and we'll have a look at that. Thank you.
Just again, thank you. I think you are doing brilliant, and to all the people that deliver, you are doing great work, and I miss my Zumba women on a Tuesday because you were all bloody brilliant.
Thank you. I've got Isabel Hunter.
Thank you, Chair. Just how do we manage to reach to the hard to reach? Because a lot of people do think that leisure centres are meant for people that really want to be active in that, and it's not. It's that bit where people need that help as to, for the, say, weight control as well as fitness, because if you're fitter, you know, as you say, longer life, it's how we reach that. Is sometimes it could be cost effective, you know, the costs of joining up to memberships, but also it's the fact of getting people through that door. It's how we get them through at the leisure centre. I know there's free ones in the parks and that, but it's just, and it's sometimes that advice that Places Leisure can give.
No, I completely agree. There is still, for some, that stigma, or a leisure centre isn't for me. It's too glossy, it's too shiny. It's so and places are acutely conscious of that. But sometimes it's the community connectors and it's the leaders that can in the community who can help cross that threshold. The likes of our health trainers, social prescribers that are already in GP surgeries. But it's also people who, you know, it could be your neighbour who is more likely to go for a walk and then act as an advocate to encourage someone. It doesn't have to be into the leisure centres, as you know full well, which is the neighbourhood design bit that I'm particularly passionate about. How can people step outside their front door and feel safe and confident enough to be able to walk down their street to their local park? Because that will make a difference, as well as the more traditional classes to go to. So there are workshops happening with places now to help co-design and develop what the Healthy Communities programme is going to look like for 25-26. And they are the exact questions that we will be asking. What we know from theory, what are the barriers, but actually what is it like for you in this particular community that would encourage you to participate more?
Georgina Hill.
Thank you. This is an interesting report. It's one of the areas where this, and credit to this administration, the investment in leisure centres. So there has been that investment. I suppose it is an area, and this would be true of councils everywhere, I think, the direct money. So I'll give you an example. In my ward, the Astro pitch is out of use. It's been out of use for months and months. I think it might be over a year now. And that means that it's needed for hockey, and it's needed for the kids doing PE. And you think that's a big impact on activity. And, you know, there is the money for the investment of the school. They say we can't draw down that. You can't get the £20,000 to rejuvenate the pitch. And that would seem, for such an important issue, not being able to address that. And I just wonder, just floating a suggestion, we have our members' small schemes, and there's a criteria, and a lot of councils have been desperately spending the last pounds they've got as it's coming to the end of the term, and there's that thing that you allow 2,000 of revenue and then it has to be capital spend. And I just wonder, it's just floating a kind of suggestion it would help if, you know, if somebody, and I have, and I know others have invested in capital schemes, sports clubs and goalposts and doing up change rooms and things. But I just wonder if it would help if we said member small schemes, if it is increasing physical activity in Northumberland, then there's a flexibility. Just as a suggestion what we could do, because like everything, money helps, and sometimes there's an abundance of money for helping these smaller local schemes.
Well, welcome those comments, absolutely, and there's a lot to be said around the understanding of what we would refer to as like the playing pitch strategy, because you're right, it is about looking at where do people go to be able to play and have good enough quality surfaces and lighting and such like to do that. So part of the refresh of the physical activity strategy, there will be the playing pitch review of which we know we've got the play zones now, and they are what used to be called the multi-use games areas, but welcome that suggestion from the small pots, because putting them together creates a bigger pot inevitably, doesn't it? And we have also looked at Town and Parish Council and the contribution that they can bring. I know they've invested in some of the play zone activity. So I think sometimes it is about that community congregating to think what is of benefit to our community, that also we can then, if we demonstrate match funding, well, where's Sport England, where's the Newcastle Foundation, and we can start to build from there. So thank you for those suggestions.
Yeah, so we're going to do a Zumba session, so if you'd all like to stand... No, so one thing that I do feel like is missing and does get raised quite a bit is about people with additional needs and disabilities within Northumberland. So I'm just wondering if there's a separate strategy, because it's something that does get raised, whether it's holiday play programmes or basically access within Northumberland, and I do feel like there's a bit of a gaping hole. So I'm just wondering, is there a separate strategy on that, and what are we going to do going forward, because it is a point that does come to me within quite a built-up area as well, so I'm just wondering if there's any focus. Thank you.
There'll be a specific component of the physical activity strategy. We've got our Ability to Play programme across the county at the minute, but we need to take stock of how targeted is that? Are we reaching the right people? Is it in the right areas? It's a finite resource, so are we making sure that it is of best use? So it will come through there, and very much working alongside SEND partnership and things to make sure we've got the voice of people directly, as well as parents and carers as well.
I think that's all the comments. Obviously, there's a lot of physical activity going on in this room, shifting leaflets and knocking on doors the next few months. But anyway, I digress. Thank you very much for the report. I think we're just to note that, aren't we? So that's that one done. Thank you, committee. I then go into item 5 on the agenda. 5A is the forward plan. To note the latest forward plan, pages 43 to 48. 5B is to consider the work programme monitoring report for the Health and Wellbeing OSC Scrutiny Committee for 24-25. I suppose nearly 25-26 really, where we are now. And then 6 is urgent business. I have no urgent business. This is my last meeting as chair. So thank you very much, committee, for all your support and all of your probing questions and interest in the subject. So thank you very much, everyone. Thank you. And with that, I'll close the meeting. Thank you.
Thank you, Chair.